So now we're going to talk about myelodysplasia, one of the myeloid hematological malignancies. So as with all the hematological malignancies, we're talking about a clonal expansion, a clonal disorder, and an acquired disorder. And because it's a myeloid lineage disorder, myelodysplasia arises from a myeloid progenitor cell. And the other thing I need to emphasize about myelodysplasia is that this really is a group of similar disorders, and it's quite a heterogeneous group. We're not going to go into details of the subclassification today in the interest of trying to give you a clear overview of the common features of the group, and also because quite likely by the time you become doctors, the classification may have changed subtly. So we'll talk about the group in general and the common features. So this is a diagram you'll probably recognize from the previous talk. Again, it's the slide of normal hematopoiesis, and this is just to show you where the abnormal progenitor cell for myelodysplasia is, and it's the myeloid progenitor cell. And this abnormal progenitor cell is capable of differentiating to a degree to produce abnormal peripheral blood cells. So we can see abnormal platelets, abnormal red cells, abnormal granulocytes, abnormal monocytes in the peripheral blood. But it doesn't affect the lymphoid lineage. So before we go into what myelodysplasia looks like in an individual patient, I'd just like to give you a little bit of an idea of who it affects. So it occurs at a rate of around 4 in 100,000. That's the incidence. So in a Wellington region, we would expect to see between 10 and 20 new cases a year. Because people live with this condition for a few years, the prevalence, i.e. the number of people that are living with myelodysplasia, is going to be between 50 and 100 in our region. So it's quite likely you will come across people with myelodysplasia. It's not common in young people. It does occur even in children, but not commonly. So if you're a pediatrician, it's going to be more of a rare event than if you're working in care of the elderly. The median age at presentation is 65. There is a very slight male predominance, but that doesn't help you diagnose your individual patient. So we've said that we want you to understand the pathogenesis of the hematological malignancies. Unfortunately, we don't always understand the pathogenesis very clearly ourselves. And for myelodysplasia, whilst we can identify a number of molecular changes, it's not yet clear how these play out in the generation of the condition. We do know that people who've been exposed to chemotherapy or radiotherapy or benzene are at increased risk. And there are very rare families in which there is a germline mutation that predisposes to the development of myelodysplasia. So now we're moving on to how does myelodysplasia present in an individual patient. And there are 3 cardinal features really. One is the presence of peripheral cytopenias. So we're talking anemia, neutropenia, thrombocytopenia, and it can be any one or any combination of those. The second cardinal feature is morphological dysplasia, by which I mean the blood cells look abnormal. And the third feature is ineffective hematopoiesis. So when we look in the bone marrow, we can see that the bone marrow is full of developing cells, but it's not effective because we're not seeing all of those cells appearing in the peripheral blood. So this slide is to show you 2 things really. One is the full blood count that might be quite typical of myelodysplasia, showing some cytopenias, so the patient is anemic and neutropenic. This patient doesn't happen to be thrombocytopenic, but they could have been. The other thing that I wanted you to see on this slide, and just a hint for help with diagnosis, is that often in myelodysplasia we see macrocytosis. And by macrocytosis I mean big red cells. And that is indicated to you on the full blood count report with the MCV, or mean cell volume, which will be raised if you have macrocytosis. So mean cell volume is referring to the red cell size, and one of several causes of macrocytosis is myelodysplasia. Obviously there are others, and that's something that you need to be aware of, but it might be a hint in a patient you think could have this condition. I should also say that not all patients with myelodysplasia have macrocytosis, but many do. So the second cardinal feature of myelodysplasia, and there's a clue in the name, is dysplasia, by which I mean abnormal looking myeloid cells. The exact abnormalities will vary a little between patients, but there are some features that are reasonably common or characteristic. This picture shows some of them. The bottom picture is actually a normal blood film. So we're seeing normal looking red blood cells. We're seeing 2 normal looking neutrophils, and some, at the bottom right hand corner, some normal platelets. In contrast, the top picture is taken from a patient with myelodysplasia, and although the red cells are really not too bad, they're a little bit varying in appearance, there is a very characteristic abnormality in this blood film, which is the white cell at the top left. So this looks vaguely like a neutrophil, but it's not quite right. A neutrophil should have 3 to 5 nuclear lobes, and this one only has 2, and they're connected by a very thin strand of chromatin, which is also not normal. In addition, the cytoplasm doesn't have any of the usual neutrophil granules. And this is a very characteristic abnormality that we see in myelodysplasia, and we refer to it as a Pelger-Huet abnormality. And if your hematologist is writing this on the blood film, I think they're trying to tell you that they think this patient might have myelodysplasia. There is also one large platelet towards the right-hand side of the picture, which is clearly very different looking to the normal platelets in the normal film. And the third characteristic feature of myelodysplasia, we said, was ineffective hematopoiesis. So these are pictures of bone marrow trephine biopsies. So we've taken a core of tissue out of the bone marrow, and in the bone marrow there is hemopoietic tissue, so developing blood cells in the bone marrow. The bottom picture again is the normal one, and in the normal one you can see there are some white spaces which are fat spaces, and they're there in the right proportion. There should be about a third of the hemopoietic marrow taken up by fat. In the top picture, which is a picture of a trephine biopsy taken from a patient with myelodysplasia, you can see that almost all of the space is taken up by the cells and there's very little fat space. So this is a hypercellular marrow. So the marrow is very active, but this patient very likely has cytopenias, so it's not effective. It's not doing its normal job of producing blood cells that appear in the peripheral blood. Sometimes the diagnosis of myelodysplasia is quite obvious from the blood count and the bone marrow findings. Sometimes it's not so obvious. And one of the things that we can do to help us make a diagnosis of myelodysplasia is to do cytogenetics. So looking at the chromosomes that are present in the bone marrow cells, so this is not the chromosomes in any other part of the patient, but just the bone marrow and blood cells, we sometimes see characteristic abnormalities. So this is a karyotype from a patient with myelodysplasia, and it shows a number of abnormalities that are, some of which are quite characteristic of the condition. So there is a loss of the long arm of chromosome 5q-. There are 3 copies of chromosome 8. There's a bit missing from one of the chromosomes 17. And there is a bit missing from one of the chromosome 20s. So that's quite a complex karyotype. Sometimes we just see one abnormality, sometimes we see multiple ones. And in addition to helping us make the diagnosis of the condition, it also gives us some prognostic information, some information about how this disease is likely to behave. So in addition to the cytogenetics, we also look at the number of primitive cells in the bone marrow, or blasts in the bone marrow, and the level of the hemoglobin, the level of the neutrophils, and the level of the platelets. And putting these all together, we can put that into a scoring system that will give us an idea of how this condition is likely to progress. Is it going to be a relatively indolent condition, or is it something that's going to progress badly and not respond to treatment? In the last slide I mentioned blasts, so I thought I'd show you some pictures of blasts. The top slide is a bone marrow aspirate. So we've sucked out a bit of liquid marrow from the bone marrow and spread it on a slide and stained it up. And in the middle there is a blast, which is a large cell with a large nucleus and open chromatin, which are all features that tell us this is a primitive cell. There is another way. We can just count these up in the bone marrow aspirate. We can also count them in the bone marrow trophine, which is the core of tissue taken out of a bone marrow. And one way of counting them in the trophine is to use one of those techniques we referred to earlier to pick up the antigens expressed on the surface of the cell. And in the bottom picture, what has been done is that an antibody directed against a surface antigen called CD34 has been added to the preparation, and the antibody has been labelled so that we can then pick up where the antibody has been bound. So we will see brown stain where there is CD34 expressed. And it's quite neat because the bone marrow has its own internal control, because endothelial cells express CD34, and you can see that this stain has worked by looking at the blood vessels that stain positively. It also stains blasts. So there are some large cells that are brown in outline, and they are CD34 positive cells. I said at the beginning of this talk that myelodysplasia is a group of disorders, and it is. So there are several different subtypes, and the natural history depends a little bit on some of the results of the specific tests that we talked about. But overall, there is a general tendency to progress slowly over time, and what tends to happen is that the cytopenias get worse. So often what happens is that patients ultimately die from complications of neutropenia, i.e. infection, or thrombocytopenia, i.e. bleeding. There is another possible outcome in that myelodysplasia can transform into another hematological malignancy, an acute myeloid leukemia. And if this happens, the outlook is poor, because that type of leukemia, a transformed leukemia, is often very resistant to treatment. So if we look at the overall natural history of myelodysplasia, the range of survival is from perhaps just under 1 year to about 9 years, except for the very rare patient who is able to have an allogeneic stem cell transplant and who has a good outcome from this. So that concludes the talk on myelodysplasia. I'd like to thank you for your attention and see you again soon.